If there's still no gold standard of measuring these efficiencies, and in fact maybe even the data is suspect, as you're saying, it's hard to measure, et cetera, why are purchasers pushing for this so hard?
Sure, and this is one of the central rubs where the provider organizations and the professional societies like the American Medical Association, they would say it's unconscionable to use any of these data when they're imperfect, and we should wait to do anything until we've got electronic medical records for everyone, and if we pull the data centrally and do this with clinical data. On the other hand, the purchasers are saying, we can't wait. We've got a crisis. We have to do something now. We have to start having consumers share costs, and we have to give them some information, the best that's available. Let's get what we have out there and make it better with time. I understand both sides' points of view. I do think that when my colleagues say there should be no public reporting until all the data are electronic and we all have electronic records that are interoperable, that does feel a little bit like saying, don't do anything until after my career is over, because we know that's going to be a long, long time.
Physicians want veto power, and healthcare purchasers or insurance industry wants veto power. Who should have it when it comes to efficiency report cards?
Well, first I'll give you the provider point of view, because as a doctor, I believe we're the only ones who really understand how complex care is, and that we should be allowed to veto anything that we don't feel good about. That I'm smiling a little bit because I'm not quite sure it's sellable in the real world, because in the real world, the consumers get to call the shots about what they want measured and how it's measured. Consumer Reports doesn't check with the auto industry on how they do rollover tests. Restaurants don't get to say how Zagat's evaluates them. So in most of the real world, consumers decide how quality and efficiency are measured. We should recognize that and try to be good participants in the discussion.
If you really are sitting as a mediator between these two groups, what kind of insight would you impart to both?
Well, I would say the same thing to both sides, really, which is that they don't need to read a medical textbook. They don't need to read Elliot Fisher's work. They should read his father's work, Roger Fisher's book, Getting to Yes. And in Getting to Yes, which is a book about negotiation, what you learn is don't focus on the other side's position. Focus on the other side's needs. And I think that we should first understand what the other side's saying and try to understand why do they need it? Why are they saying that? And then we should try to figure out how can we accommodate the other side's needs in a way that we can live with. So the kinds of things that Arnie Milstein and I talk about in the last part of the article are some middle grounds where public reporting on individual doctors may not be needed if physicians will take incentives to actually improve efficiency and quality. If there are no quality metrics in an area available for like a condition like total knee replacement or something, perhaps efficiency reporting can be delayed until quality measures are developed so that both quality and cost data go out together at the same time. So I would just say that if you're really going to get involved in negotiation, then you really should understand the other side's points of view, understand their needs. Those are critical steps in the process, and that's what we hoped our article would help foster.
Thank you, Dr. Lee.
My pleasure.